diuretics. Yeah, the potassium sparing diuretics, they causing hyperkalemia. This you must keep in mind. This one important thing. Another, spironolactone cause gynecomastia. One thing, another thing, they causing acidosis. So why they cause acidosis? Because they disturb the potassium. Potassium, when you have hyperkalemia, automatically induce acidosis. In hyperkalemia, in our body, what happen if you have hyperkalemia? This potassium here, hydrogen here, and potassium here. Okay. If you have hyperkalemia, this potassium going inside, the hydrogen automatically coming out because you have hyperkalemia. So hyperkalemia automatically induce what? Acidosis. So hyperkalemia here, the acidosis here. What the finding of hyperkalemia? We having the ECG wave here. It's a T wave, very tall T wave. Okay, very tall T wave is a feature. Peak tall T wave is a feature of hyperkalemia. Tall T wave. Tall T wave is a feature of hyperkalemia. So hyperkalemia also not a good thing. Understand? So you must shift the patient to again thiazide or leucardic because they eliminate extra potassium. When extra potassium eliminate too much, patient now in hypokalemia, you again can shift on potassium sparing diuretics. Understand? Amiloride. Come here. The amiloride. Amiloride we use for diabetes insipidus. Okay. Again, nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. And this amiloride, the potassium sparing diuretics amiloride also have another use in case of lithium toxicity. It's a very special drug. These two uses must keep in mind about amiloride. Amiloride is a drug of choice if the patient has lithium. Do you remember lithium? Lithium we use
Yes, sir.
for bipolar
Or
disorder.
mm,
Bipolar disorder, lithium. If the lithium toxic, lithium also disturbs your thyroid, hypothyroidism. Lithium disturbs your CNS, seizure there. Okay, lithium have a lot of side effects. So this lithium, if lithium toxic, you need to eliminate this lithium. The best drug to eliminate the lithium is amyloid. Keep in mind. For lithium toxicity, diabetes insipidus induced by lithium also induce diabetes insipidus. You must give amyloid. If the patient having diabetes insipidus just because of any other reason, nephrogenic diabetes insipidus, you again give amyloid. Amyloid is the best drug for diabetes insipidus and lithium toxicity. Okay, you must keep in mind these 2 points about amyloid, and also not mix amyloid with spironolactone and apelritone. Spironolactone, apelrinone, these two drugs are aldosterone receptor blockers. Okay, and amyloid and triamytrine, these two drugs they work on sodium potassium counter transport mechanism on principal cells. This is spironolactone, apelrinone, they enter to principal cells. Spironolactone work here, okay, and block this aldosterone receptor. Understand? It's a different action. It's a different action, but the function same. You can see, but the function same. If you block the pump, then this counter transport mechanism also are automatically working very slowly. If you directly block this counter transport mechanism, also another thing, another way to stop this counter transport. Clear? There are two ways to save the potassium here. So these four drugs is also known as the potassium sparing diuretics. All about all diuretics. Okay, potassium sparing diuretics. The potassium sparing diuretic spironolactone is also the drug for heart failure. It's also now some books they write there's also the gold standard help in remodeling of heart. Okay, help in decrease mortality in heart failure. Beta blocker decrease mortality. Okay, in MI patient. Spironolactone decrease mortality in heart failure. It's a mortality decreasing drug, spironolactone. Okay, spironolactone is a mortality decreasing drug. Spironolactone in case of ascites, the patient have ascites, we give spironolactone, very good drug in ascites also. Okay, The problem with spironolactone, they causing gynecomastia. They disturb the androgens, okay, because it's act like androgen. And another side effect regarding pH can induce acidosis. Can induce acidosis. Clear? The other diuretics causing acidosis, carbonic anhydrase inhibitor, they also induce acidosis because they eliminate base and not allow CO2 going out. Yeah, this is already done. So these are all the five classes related to diuretics. Okay. Now we move on to the next topic. Next topic we will start for anticoagulants. Okay, anticoagulants, anti-clotting drugs. Next section, anticoagulants, anti-clotting drugs. To understand the all this may be a bit hard for you guys. Name also difficult, but sure, the basic idea is the same thing. If you know about the physiology about the clotting system, you usually can understand how these drugs are working. Okay, the the first thing the in the clotting system, what we use in clotting system, how the clotting system start when endothelium injury here, the primary hemostasis. Yeah, primary hemostasis is done by platelet. The first thing, the platelet form the loose plug there, the clotting system. In the clotting system, these anticoagulants we use here anticoagulant because there are a lot of diseases called thrombosis because of thrombosis stroke. We use for DVT induced pulmonary embolism, and we use for MI patient, and we use for if any patient having stent surgery for the MI. Okay, the stroke patient, DVT patient, pulmonary embolism patient, MI patient, the stenting. Okay, so this MI angina patient, unstable angina patient, we also use these anticoagulants. The anticoagulant, the anti-clotting drug that disturb our clotting system. So first we must categorize how they act. Okay, they act on primary or they act on secondary hemostasis. Secondary, clear? They act on primary system, act on secondary. The primary hemostasis is done by what happened normal physiology in primary hemostasis. We just activate what? Activate platelet. Activate platelet. Yeah, activate platelet. This platelet make a plug. One, two, three, four. This platelet attached with endothelium. Platelet attached with endothelium. How the platelet attach with endothelium? The platelet attach with endothelium with the help of von Willebrand factor. With the help of von Willebrand factor. Another thing, the platelet have the glycoprotein 1. Platelet having the glycoprotein 1. This is adhesions of platelets. The first step of primary hemostasis was adhesions. Okay. The next step is your aggregation of the platelet. Understand? With the help of prostaglandin, with the help of especially thromboxane. Thromboxane during is also inflammatory mediator help to collect the platelet and make the clot. Okay, the thrombosis. Glycoprotein 1 here we use here the glycoprotein 2 for aggregation, 1 for adhesion, 2 for aggregation. Okay, so in this primary hemostasis, we use the things here. We use the things here. Von Willebrand factor, number one. Okay. Another glycoprotein one. Glycoprotein one. Okay. And for second thing, we use here glycoprotein 2A, 3B, 2A and 3B. This for aggregation. This for aggregation. The receptor of this glycoprotein 2A 3B, the activation of receptor done by ADP molecule. Okay, this ADP also released by platelet. So drugs acting on platelet, these are the drugs acting on platelet. They block glycoprotein, they block ADP. Okay, they not allow the platelet aggregation. They not allow platelet aggregation. Understand? They just disturb the platelet activity. They disturb the platelet activity. So we can describe here the group here. So this group just known as, so these drugs belongs to antiplatelet drugs. Understand? Antiplatelets. So antiplatelets, how they working? How the platelet are coming together? The platelet, the thromboxane. If you remember, cyclooxygenase COX pathway, yeah. Cyclooxygenase pathway produce two things. Number one, prostaglandin. Another was lipoxygenase pathway, production of leukotrienes. Also production of one thing, thromboxane. Cyclooxygenase pathway also help to produce thromboxane. Okay, prostaglandin causing what? Vasodilation, and thromboxane causing what? Thromboxane, very strong activator of platelet. So drug blocking, drug can directly block the COX pathway. Drugs block the thromboxane. Okay, drug block the COX pathway, drug block the thromboxane. If they block the thromboxane, it means they not allow platelet aggregation. One, the first step. You can block this step. You can block COX pathway if you remember aspirin. Okay, aspirin is anti-platelet. Aspirin is anti-platelet. The other drugs, they're working against glycoprotein. The other drugs are working against glycoprotein 1, working against glycoprotein 2, working against ADP receptor. Okay. The number one thing, the platelet activation is blocked. One thing. Okay. Another thing, you can block the platelet adhesion. Another thing, you can block the platelet aggregation. There are three steps there. First thing, the platelet come there. If you not allow the platelet aggregate at the one area, you block the COX enzyme. So there are three ways to block the platelet. Understand? There are three ways to block the platelet. So anti-platelet. If you using anti-platelet, if you're using anti-platelet, what thing you need to monitor? You must check the bleeding time for platelet. Bleeding time for platelet. Understand? The bleeding time for platelet. So bleeding time, you must check the bleeding time. If the bleeding time is prolonged, then you need to avoid platelet. If the patient have platelet number very low, then I can't use anti-platelet if platelet already very low. Okay, the patient can have very big bleeding inside the brain, inside the liver. So we must manage these drugs by using bleeding time. So these drugs we control by bleeding time. The patient must have investigation like the bleeding time. If bleeding time prolonged, then we must stop this drug. Okay. The second secondary hemostasis, we make the clot there on the platelet. Okay, to make the clot, we need to stop the clot. Yeah. So we have two pathways. Number one, intrinsic pathway. Number one, intrinsic pathway. Number two, extrinsic pathway. Intrinsic pathway. In intrinsic pathway start from 12. Extrinsic pathway, if you remember, start from tissue factor, then factor number 7. Yeah, tissue factor is factor number 3. Factor number 3, then factor number 7, then factor number 10 directly. This pathway start from 12, 11, then going to 9, then directly activation euro 10, then also using factor number 8. Okay. So intrinsic pathway, after this intrinsic pathway is using factor number 2. Here we also using factor number 2. Yeah. So this is your clotting cascade, extrinsic pathway and intrinsic pathway. Extrinsic pathway, how you control extrinsic pathway, how you know extrinsic pathway have problem? When you have hemophilia. Hemophilia is a disease of factor number 8, disease of factor number 9, disease of factor number 11. Okay. So if for intrinsic pathway, which test we perform for intrinsic pathway? We need to perform APTT. APTT. Okay. For extrinsic pathway, we need the test here, PT, porothrombin. Done? Porothrombin. Till here clear or not? Okay, now we summarize the drug here, APTT and PT. So if you're using heparin, you remember heparin?
Yes, sir. Heparin.
Okay, heparin have many types. So later we talk about heparin. Heparin, another famous anti-clotting drug, warfarin. These two drugs. Okay, warfarin is the vitamin K and not potassium. Okay, not mixed with potassium. It's a vitamin K antagonist. So warfarin block extrinsic pathway. Understand? Heparin block intrinsic pathway. Heparin block intrinsic pathway. So if you're using heparin, you must measure patient APTT. If you're using warfarin, you must measure the patient prothrombin. There must be check and balance. If you're using too much, okay, heparin or warfarin, you must control the clotting profile also. It may lead to bleeding because you're using anticoagulant. Okay, heparin especially work for intrinsic pathway, and warfarin working against extrinsic pathway. Understand? Warfarin working against extrinsic pathway. So these two drugs here. The first one, the older one, heparin and warfarin. Now we have a lot of other drugs. The other drugs like the drugs acting on factor number 2. Factor number 2. What is factor number 2? Porothrombin. The drug acting on factor number 2. Number 1 drug, number 2, number 3. The drugs directly acting on factor number 2. They block which factor? They block factor number 2. Another drug group, number 4. The common thing in both pathway, factor number 10. The drug acting on factor number 10. Okay, drug against factor 10. Drug against factor 2. Understand? The drug against factor 10. Drug against factor 2. First we classify how many groups we use here. Okay, heparin related drugs, warfarin, thrombin antagonist, factor number 10 antagonist. Factor number 10 antagonist. Understand? Factor number 10 antagonist. So these 4 drugs, they block intrinsic and extrinsic pathway. They block the clotting. Our first aim, there must be no clot. If there must be no clot, the first step, you avoid platelet aggregation. So our first priority, listen here carefully, okay? Our first priority, we must block platelet. We use antiplatelet, okay? If already plugged there, then you use anticoagulants for intrinsic and extrinsic pathway. Understand? For intrinsic and extrinsic pathway. If the already clot there, clot is formed there, our third group was, so these drugs working against intrinsic and extrinsic pathway. Intrinsic and extrinsic pathway. Another group known as thrombolytics. If already thrombus formation there, thrombolytics. What these drugs doing what? These thrombolytics, they break, you also can give name to them, fibrinolytic. It's more better name, fibrinolytic. Yeah, they break the fibrin. Fibrinolytic, thrombolytic, same name. If the thrombus already formed, okay, first we try to avoid platelet, not activated, no adhesion, no aggregation, no activation of platelet. The drugs used against platelet, drug used against clotting factors, but still clot there. If clot is already formed, now let me know. If the person come to you with brain stroke, ischemic brain stroke, If the person come to you with the MI patient, yeah, have angina attack, unstable angina, or MI heart attack, which drug to use? Clot already formed. You directly, your first choice, antiplatelet? No. Anticoagulant? No. What's your first choice? Because clot already formed, okay? If clot already formed, then I must go for thrombolytics first. Yes, of course, must go for thrombolytics. How much time you have? You have 30 minutes. Understand? Within 30 minutes, if the clot is broken, now you want to send back home, patient send back home. Now use which drug? Use antiplatelet, okay? Use anticoagulant, not allow again clot form. If clot is already formed, then you break the clot. Understand? If clot already formed, then you break the clot. So this drug is your first line drug for brain stroke, is your first line drug for MI patient. Understand or not? Clear or not? Okay. You want to prevent next reformation of the clot. If clot again reform, you want to prevention. For prophylaxis, you want to prevent, there must be no clot there. Next time there must be no clot. Use antiplatelet, okay? Use anticoagulant like heparin, like warfarin, like the drugs against factor 2, drugs against factor 10. Understand? If clot is already formed, so what do you think about these two groups? This group, warfarin, heparin, and these two groups, the antiplatelet, these two groups for prophylaxis, okay? Prevention of DVT, prevention of pulmonary embolism, prevention of MI, prevention of brain stroke. Patient have risk for DVT, give heparin. Patient have a risk for pulmonary embolism, give heparin or warfarin. Okay, understand? Give antiplatelet, give anticoagulant. What's the use of thrombolytics? What are the thrombolytics? Thrombolytics, when the event done is when clot is formed. Yeah, it's time to break the clot. It's time to break the clot first. Patient come in emergency with MI, use thrombolytics. Understand? Use thrombolytics. These thrombolytics doing what? If you remember, normal fibrinolytic system, plasminogen activate to plasmin. Plasminogen activate to plasmin. This plasmin doing what? This plasmin break the fibrin clot. Yeah, the clot is formed by fibrin at last. So this plasmin. So the thrombolytic drug they activate what? The thrombolytic drug activate activate the plasminogen. Understand? Summary done or not? For clot formation, you need what? Platelet. For clot formation, you need what? Clotting factors. Understand? Intrinsic pathway and extrinsic pathway. Factor number 2 very important. Factor number 10 very important. Okay. Drugs working against factor number 2, drugs working against factor number 10, drugs working for extrinsic pathway, drugs working for intrinsic pathway. So this is your requirement, platelet and clotting factor to form the clot. Okay. If any patient have risk for thrombus formation, have risk of embolism, have risk of DVT, then you use which drug? Use antiplatelet, use anticlotting, yeah, to prevent the clot formation. So it's mean these two groups. Patient have cabbage procedure like coronary artery bypass surgery. Patient have prosthetic valve. Patient have, you put the stent inside the heart, yeah, to stent the inside the coronary vessel, inside the coronary vessel. So which drug you use for next time? You the patient, you must avoid that next time no clot formation there, yeah. So we use prophylaxis, prophylactically use antiplatelet, prophylactically use anti-clotting factor. Understand or not? So these two groups to prevent the clot formation. If clot formation done, if the event is done, the third group, I have another group. If the clot is done, the clot done, I break this clot by using which drug? Thrombolytic. Understand what time we use which drug?
Yes, sir.
If you are at risk, okay, if you are at risk of brain stroke, if you are at risk of DVT, if you are at risk of pulmonary embolism, understand or not? Okay, if you
Mm.
are like you have leg fracture, now the doctor advised you 3 4 months bed rest. So use what? Use prophylaxis.
Thrombolytic.
Now again you're going the wrong way. For prophylaxis, I am going for prophylaxis.
Oh,
If DVT not yet done, if DVT done, then go for thrombolytic. If DVT do something, embolism like thrombus formation there. If event is done, then go for thrombolytics. Okay. If event not yet started, you at risk now. Okay, you at risk now. All the risk factor there. Then you use prophylactically anticoagulant drug. Then you use prophylactically antiplatelets. Okay, the anti-clotting drug, anti-clotting drug, the working against clotting factor, warfarin, heparin, the drugs working against factor number 2, drugs working against factor number 10. Understand?
yes, 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 sir.
So this group we use for prophylaxis. For
Prophylaxis.
okay. Okay. Now you treat the patient. One patient come to you with brain stroke and MI patient, and now you the first we use what? First we use at hospital. At hospital, I start thrombolytics. I break that clot. Okay. Now that clot again can reform. Understand? Again can reform. For next time, you want prevention, yeah. You save the life of the patient. You are the cardiologist, you will save the life of the patient using thrombolytics. Using thrombolytics at hospital, patient was on time in hospital, yeah, in emergency. Now to save the life, now send back this patient after stabilized. The patient now stabilized, now settled. You send back to home. And you send back to home. What you give to patient? Antiplatelet. What you give to patient? Maybe heparin, okay, maybe warfarin, maybe drugs working against factor 2. Why? Because you don't want next time again clot form, yeah, because we know that patient have atherosclerosis, next time again can of course thrombus formation there. One time you break, if the clot formation done, then use thrombolytic. If you want prevention, okay, next time already done clot formation, thrombolytics use, okay, now next time again can form, then start what? Then start heparin or warfarin to prevent next time clot formation. Clear? Next start antiplatelet. Understand? To prevent next time clot formation. If the patient at risk of DVT, patient at risk of brain stroke, patient at risk of next heart attack, so what you give to patient? Prophylactically antiplatelet, prophylactically drugs working against clotting factor. So thrombolytic, what's the use of thrombolytics? It's a use in emergency situation. For what purpose? If when the clot formation is done, to break that clot, thrombolytics have some criteria to use. Thrombolytics you only apply within some time limits. If the time limits more than 90 minutes, then useless to use thrombolytics. Listen here carefully. Useless to use thrombolytics. Why? Because fibrin, if take more than 1.5 hours, that fibrin still not broken down done by plasma. That's the plasmin. Okay, thrombolytics are useless. The one thing, the clot stability. Another thing, I'm thinking about the survival of the cell is useful or not, because thrombolytic a bit expensive therapy, okay, a bit expensive therapy. If within 4 5 minutes, within 10 minutes hospital was near, the patient have heart attack, and now the patient in emergency, now of course we have the preference here thrombolytics. The best option must be PCI, okay. The best option to break that plaque, do PCI. If PCI not available, then go for thrombolytics. Understand? Sometimes small setup, small hospital, they not have like they not have well educated cardiologists, well expert cardiologists there to break that plaque for PCI procedure. If the PCI not available at the setup, then you go for thrombolytics. Clear? Then you go for thrombolytics. So thrombolytics is not your first priority. Here, the first thing to break the clot in case of heart, we must use PCI. Okay, pulmonary is your percutaneous coronary intervention. Percutaneous coronary intervention is the first for MI. Yeah, for transmural MI. The second option was thrombolytics. So thrombolytics, one thing, the priority, okay, if you just have thrombolytics, not have PCI, then only here now life-saving is your thrombolytics. Thrombolytics, if the time is too much, is more than 90 minutes, then that time thrombolytics also sometimes useless because fibrin become more stronger and not thrombolytics still even not able to break that block. Okay, this happen. So it's a basic idea about this. Okay, it's a basic idea about this. The thrombolytics and this drug, so when you're using the drugs working against clotting factor, you must monitor PT, you must monitor APTT, and the ratio of these two is known as INR. Okay, INR. So we must control this. If you're using antiplatelet, then you must manage repeatedly doing the BT, perform BT test to check it. If BT prolong, then you need to stop antiplatelet. Okay, then you need to stop antiplatelet. If the PT prolong, then you need to stop the anticoagulation drugs. Yeah, understand or not? The naming of drug, inshallah, tomorrow I will explain these anti-clotting drug, anti-platelet drug, and how we use for what purpose. And the uses are same. Okay, uses are same, not a new things. The uses are same, simple. You just to keep in mind. Very easy uses for the stroke, for DVT, for pulmonary embolism, for MI after stenting. After stenting, MI, pulmonary embolism, DVT, all drugs the same uses, nearly same uses. Okay, clear? Stroke, DVT, pulmonary embolism, MI, and stenting. Stroke, DVT, pulmonary embolism, MI, and stenting. Okay. Okay, inshallah, tomorrow we will discuss these drug name in detail and their uses and their side effects. Okay. It's your last topic of CVS. It's also related to CVS because you can see in the stent we use this drug, in MI, in Jana we use this drug, so the pulmonary embolism also related to cardiovascular system, DVT also related to cardiovascular system. Okay, the stroke is also related to vascular system, so that's why I discuss in this section anticoagulants. Okay, see you tomorrow, inshallah. Assalamu alaikum.
Waalaikumsalam. Thank you, sir.
Waalaikumsalam. Thank you so much, sir.
Waalaikumsalam, sir. Thank you so much, sir.
Welcome.
Bye-bye, guys. Annyeong.